Okay, so let's start recording. Okay, so for today's discussion, it's about somatic symptom and related disorders as well as dissociative disorders. So let me just clarify the the last uh, the last topic that we are going to cover is chapter 6. I know I said it was mood disorders. I'm so sorry about that mistake. I forgot that we are on a new calendar, so that's why I thought we will still be able to get to the mood disorder. So anyway, with that being out of the way, let's see the outline. Alright, so with a somatic symptom disorder and related disorder, we are going to be talking about four of these disorders: the somatic symptom, the illness anxiety, the psychological factors affecting medical condition, and then of course the conversion disorder. After this, we also have the dissociative disorders, which starts first with depersonalization, derealization disorder, dissociative amnesia, and dissociative identity disorder. Now, before we go through any further, please again take notes. Write down the questions that you're going to ask during the clarification schedule or the synchronous classes so that we can address them, because again, I don't know all of the class questions or things that what part confuses you in this particular discussion, or even in the textbook, or even in the DSM 5 TR. So I wouldn't know unless you would ask, okay? Okay, so what are the focus questions that we'll try to answer with this particular chapter? First off is of course the features of somatic symptom disorder, and then how are these treated? And then when we get to the dissociative disorder, what are the features of this disorder, and how do dissociative disorders develop? So let's go through a video overview of the somatic symptom disorder first. So this is from Osmosis. You can look it up in YouTube.
Somatic symptom disorder, which used to be called somatization, or somatoform disorder, involves having physical symptoms that aren't explained by any known physical or mental disorder. In other words, symptoms that can't be explained. That said, individuals aren't faking the symptoms. These symptoms are real and often made worse by the fact that they can't be scientifically explained. And this is pretty different from situations where an individual with a factitious disorder might fake an illness or injury in order to get attention. The diagnosis requires that individuals experience some set of unexplained physical or somatic symptoms for at least 6 months. The symptoms experienced by individuals with this disorder, though, can be incredibly varied. Everything from pain to gastrointestinal problems to sexual symptoms. And although the somatic symptoms are chronic, the exact location, kind, and severity of the symptoms typically changes over time. The one symptom that does often persist over time is pain, and because it's persistent and has no clear underlying cause, it can be particularly hard to treat. Somatic symptom disorder often causes cognitive symptoms as well, and these include persistent thoughts and feelings about their symptoms. Usually a lot of worry and anxiety, and sometimes even catastrophic thoughts about death. More often than not, it's these cognitive symptoms in response to the physical symptoms, more than the physical symptoms themselves, that become a basis for this diagnosis. In fact, clinicians rate the severity of somatic symptom disorder based on patient experience with these cognitive symptoms, not the physical ones. The condition's considered mild if there's only one cognitive symptom, like ruminating a lot on the symptoms. It'd be considered moderate if there are 2 or more cognitive symptoms, like rumination as well as anxiety. And it'd be considered severe if there are two or more cognitive symptoms, as well as multiple physical symptoms, or one severe symptom, like severe pain. These cognitive and physical symptoms often disrupt an individual's daily life, as well as their relationships. Unfortunately, the diagnosis can be tricky and confusing given that the symptoms shift over time and there's no clear underlying scientific explanation. Historically, it was thought that somatic symptom disorder was the result of a person having too much psychological stress, and that excess stress bubbled over and led to bodily symptoms. A current theory, though, is that individuals with this disorder are extremely sensitive to changes in their bodies, and that common experiences like indigestion might be amplified in these individuals. One everyday example of this would be how different individuals might perceive the same amount of spiciness very differently. For some people, it's tasty, and for other people, the exact same amount of spice is perceived as pain. Now, treatment of somatic symptom disorders aimed at reducing the cognitive symptoms, and this is often done through cognitive behavioral therapy. The goal here is to encourage individuals to engage in behaviors they think are limited because of their physical symptoms, in order to show them what they're able to do. Alright, as a quick recap, somatic symptom disorder involves physical symptoms that can't be scientifically explained by any known physical or mental disorder, and the most common one is pain. And these physical symptoms often lead to cognitive symptoms, like rumination and anxiety.
Alright,
What's up, guys? Just wanted to get.
that's it for the overview of the video. So as we have watched, the disorders were known as before as the somatoform disorder. Okay, so before it was called the somatic symptom disorder, it was known as the somatoform disorders. Um, Now, the word soma means body, so more or less the main feature of this disorder is the preoccupation with the physical symptoms or health concerns. So, yun yung pinaka main features na makikita natin dito. Um, Before actually the body dysmorphic or BDD, as we have discussed in the OCD and related disorders, it was clustered under this particular group of disorders kasi nga ang akala nila, or since it has something to do with the body, they felt, or the practitioners in the field during that time felt that it was correct to put it in that particular group. However, upon further study, ang nakita nga nila, the BDD is more on obsession about perfection in the body. So may obsession and then may compulsion in the particular action of either um, exercising too much in order to get the perfect air quotes body shape, or undergoing several surgeries para makuha mo yung perfect na itsura na gusto mo. So, after that, they change it to, or they put the BDD under the OCD. And then, retained with the somatic disorders na talagang more on the preoccupation with the illnesses or pain in the body. Okay. So, again. So, usually people with this kind of disorder have, are, they ruminate. And when we say ruminate, they have this preoccupation, or they always think about their health or the symptoms regarding their health. So, like for example, yun, nararamdaman niya, masakit yung ulo niya for quite some time, then probably kung ano-ano nang iniisip niya doon sa pagiging masakitin ng ulo niya. So, more or less they have physical complaints. Yun nga yung usual na meron tayo or meron sila, like for example, headache, or yung most common is of course the gastrointestinal pain or something similar to that, or something that has something to do with that. Okay? And it doesn't have any identifiable medical condition. So, ano ibig sabihin nun? Ibig sabihin nun is that when they feel like, for example, headaches, they don't really have a history of migraines or anything that would cause them to feel headaches. So, kumbaga parang walang problema, pero for them, it's a big issue. So, kaya nga naging disorder na siya. So, there are several types of somatic symptom disorders. So, the first one that we're going to be discussing is the somatic symptom. And then, of course, the illness anxiety disorder, and then psychological factors affecting medical condition, and lastly, the conversion disorder. So, the somatic symptom disorder had been identified by a French doctor who noticed na ang dami niyang pasyente nung time na yon na pupunta sa kanya, sabihin, oh, masakit yung ganito ko, masakit yung ganyan ko. Lahat ng pasyente niya at that time, parang ang daming masasakit sa kanila. However, pag chinek niya naman or inassess niya, wala siyang nakikitang rason kung bakit may mga sumasakit sa kanila. And the said doctor is known as Briquet, because French, okay? So, it was called before, or the somatic symptom disorder was called before as Briquet syndrome. So, okay. Now, with somatic symptom disorder, it's usually there is a presence of one or more somatic symptoms. So, please listen carefully kasi this is already the features. And usually, it's quite confusing to distinguish if it's somatic symptom or if it's illness anxiety disorder, because the similarity between the two is very high. So, presence of one or more somatic symptoms, again, we are talking about bodily pains, and then the symptom is often medically unexplained, meaning to say, kahit nagpa-lab test na siya clear or all negative yung mga lab test niya, pero persistent pa rin yung nararamdaman niyang sakit or complaint kung saan man niya nararamdaman yung part ng body na yon na may sumasakit. And then they have excessive thoughts or feelings and behavior related to the symptoms. For example, excessive thoughts about the seriousness of the symptom, and yung sasabihin na bahala, baka cancer na to, yung mga ganon. And frequent complaints and requests for help. So they usually go to the doctor to ask about this condition, kahit again, wala nga, or kahit nakailang second opinion na sila, pero wala talagang makita sa mga doktor na pinupuntahan nila. They also have a lot or high health-related anxiety, and they do excessive research about the symptoms that they are feeling. And of course, it usually would cause impairment in social or occupational functioning kasi nga, since ang daming sumasakit sa kanila, you can just imagine the number of leaves that this person would take from work, and also the number of social events that this person would decline kasi nga they would say na, teka, papakiramdaman ko muna yung katawan ko kung kaya ko ba or hindi. So, very excessive yung kanilang judgment in terms dun sa pain na nararamdaman nila. So, let's see the diagnostic criteria. Again, we're using the DSM-5-TR. Wala naman siya masyadong difference actually, but it would not hurt to see the latter part of the section, yung mga diagnostic features, kasi may mga bagong study sa TR. Okay. So, sabi niya, one or more somatic symptoms that are distressing and or resulting and significant disruption in daily life. So, katulad ng sinabi ko, the person might be incurring a lot of absences at work dahil nga sa sobrang preoccupied niya sa somatic symptoms niya. Another is the excessive thoughts, feelings, and behaviors related to somatic symptom or associated health concerns as manifested by at least one of the following. So first one is disproportionate and persistent thoughts about the seriousness of one's symptoms. So pwede yun nga na they would, the simple headache, they would associate it already with cancer or whatnot. Kasi nga parang lagi, the past few days they would notice na sumasakit yung ulo nila. And then they have high levels of health-related anxiety, or they might have excessive time and energy devoted to these symptoms or health concerns. So, yun nga. Mas madalas pa siya sa office ng doctor or sa clinic ng doctor kaysa sa mga dapat niyang pinupuntahan. Okay. Although any one symptom may not be continuously present, the state of being symptomatic is persistent, typically for more than 6 months. So, ito yung duration natin. So, hindi siya kailangan na araw-araw, kung may nararamdaman siyang masakit yung ulo niya. But in a month, siguro, nararamdaman niya yon, and then yung pagkaramdam niya nun, very excessive yung reaction niya. Let's say na parang sa 1 month na yun, naramdaman niya yung sakit ng ulo, nag-leave siya for 1 week. And then yung 1 week na yun, or after that 1 week leave, nagpa-check up siya the following week. So, 2 weeks na yun nawala sa kanya in terms of work or school. And then, the following month, ganun na naman yung naramdaman niya. Ganun na naman yung ginawa niya. So, there is the pattern of behavior that you would see within that more than 6 months period. And then with the specifier, you need to specify if the condition is predominant pain. This is also known as pain disorder before, pero under na lang siya sa specifier. So, ito is kung yung client ay ang somatic complaints niya ay yun nga, more on may masakit sa kanya. So, yun ang pwede mong ilagay. And then, the current severity, mild, if one of the symptoms in criterion B is fulfilled. Moderate, if 2 of the symptoms in criterion B are fulfilled. Or severe, if 2 or more of the symptoms in criterion B are fulfilled. Plus, there are multiple somatic symptoms. So, again, moderate siya kung ito lang, 2 lang or 3 ang nakuha niya. Or severe siya kung nakuha niya yung 2 or 3 and then hindi lang isa but more than 2 or 2 or more somatic complaints pa yung nirareklamo niya. Hindi lang may masakit, may sasabihin pa siya na feeling ko yung gantong parte ng tiyan ko, ganyan. So, severe na yung level na yun pag ganun yung sinabi ng client. In terms of the statistics, this is actually a relatively rare condition. However, the onset or what they have found in the patients diagnosed with that is that it can start during the adolescence. And then, what they also saw in the statistics is that it is more likely to affect unmarried women and women from the lower socioeconomic strata. So, yung mahirap at saka yung mga single na women, yun daw yung nakakaranas nito. And it usually runs a chronic course. Kasi nga, mahirap nga dyan since walang medical data to back up their claims or to really know what they are going through. Matagal nilang nararamdaman or matagal silang nagsusuffer with this kind of disorder. Okay. With regards to the research, so ito yung sinasabi ko sa inyo kanina, definitely may bago na sa DSM 5TR, sorry. Kasi nga, this one, it was just redefined using the DSM-5. So, meron na nga yung mga bagong statistics and data regarding that using the DSM-5TR. So, that's why I'm suggesting that you look it up. Okay, now moving on to the illness anxiety disorder. The illness anxiety disorder naman, this is very similar to the DSM-4's hypochondriasis. So, in the DSM-4, ang tawag dito was hypochondriasis, and the clinical description are the following. Severe anxiety about the possibility or of having or acquiring a serious disease. So, yung, sige, mamaya ko na ipipinpoint yung difference yung dalawa. Actual symptoms are either very mild or absent. There is a strong disease conviction, and despite going to the doctor, medical reassurance does not seem to help. So, the difference between the illness anxiety and this one is that with the somatic symptom disorder and illness anxiety is that with somatic symptom, it's focused on what they are feeling in the body. So, more or less, yun nga, yung pain, sabihin nila, may pain ako nararamdaman dito, may ganito, ganito, ganito. Ito naman, ang focus niya or main feature niya is baka may ganun na siyang sakit or baka may sakit na siya. So, and then, another difference between the two is also how they react with medical professionals. With somatic symptom disorder, although punta rin sila ng ospital, they don't really, kumbaga, hindi siya, hindi siya katulad ng attitude ng illness anxiety disorder na parang mas marunong pa sa doktor. Kasi nga, again, they have a strong conviction about the disease. So, sabi niya, meron nga ako niyan eh. Kahit nasasabi ng doktor na, hindi, wala ka niyan. Or, based from the lab test and all of the things that I have checked, wala ka niyan. Sabi niya, hindi, ganito nga. Bakit ko nararamdaman yon? Whereas with the somatic symptom, the pain may persist, but kahit na anong sabihin ng doktor nila, they don't really counter it much. Pupunta na lang siguro sila sa ibang doktor. Pero, nandun pa rin yung nararamdaman nilang pain. Okay, let's talk about the symptoms. The symptoms are the following. So, we have of course the preoccupation with fears or having or acquiring a serious illness. So, again, ito yung main feature niya. And then the somatic symptoms are not present, or if present, they are only mild in intensity. Kaya nga, again, ang sabi ko sa inyo, with the somatic symptom, mas nakafocus siya doon sa pain, kung meron pain na nararamdaman niya. So, nakafocus siya sa symptom. Ito, nakafocus siya sa sakit. Kung meron man siyang pain na nararamdaman, it's not that severe. Ayan. If there is another medical condition or if there is a high risk for developing a medical condition, the preoccupation is clearly excessive or disproportionate. So, like for example, ano ba yung isa? Yung isang kakilala ko, nakita niya na nilalanggam yung ano niya, yung pinya, yung ihi niya. So, that friend has a family history of diabetes. So, he immediately went to the doctor and had himself checked. So, sabi niya doon sa doktor, parang, Dok, meron na po yata akong diabetes. Tapos sabi ng doktor, parang, what's your, parang, paano mo nasabi na meron ka ng ano bang nangyari? So, the doctor, of course, was expecting more physiological symptoms, like, for example, na, pag hindi ako kumakain, ganito, yung parang pag bumababa yung sugar, yung mga ganong bagay. Pero ang sabi niya lang was that, kasi nakita ko nilalanggam yung ihi ko. So, parang in-equate niya na yon na dahil nilalanggam, matamis siguro yung ihi niya, and then, therefore, meron siyang diabetes. So, the doctor checked the, the friend, the doctor checked my friend to see if he has diabetes. Sabi naman ng doktor, so far, wala pa naman daw. But then, given the history, may possibility. So, diba, we know about the risk factors. So, may possibility na magkaroon siya later on. And also, if he doesn't really watch his diet. But he was still insisting that he now has diabetes because of what he saw. So, ganun katindi yung pagkakasabi niya. Kaya nga, based from that particular anecdote of my friend, sabi ko, mukhang may illness anxiety to. Because of that, na-check na siya ng doctor. He was run with several tests. Pero it came out clear, it came out negative. Pero siya, ini-insist niya pa rin na, no, I have diabetes. I can feel that I have diabetes. So, ganong level yung insistence niya. And then, they also have high level of anxiety about health. And the individual is easily alarmed about the personal health status. So, like with my friend niya, na nakita lang ng, ng langgam dun sa ihi niya. At nag-iisang langgam lang. He was already insisting that he has diabetes. So, the individual performs excessive health-related behaviors like repeatedly checks his or her body for signs of illnesses, exhibits maladaptive avoidance like avoids doctor's appointments and hospitals. So, there are people like that. Not all people na may somatic disorder are frequent visitors of the hospital or always have doctor's appointments. Some of them would go to lengths of avoiding the doctor. The illness preoccupation has been present for the past 6 months, but the specific illness that is feared may change over that period of time. So, another big difference between the somatic symptom and the illness anxiety is that with the illness anxiety, parang in the course of 6 months period, pwedeng paiba-iba na yung preoccupation niya na sakit. Pwedeng this month, diabetes, the next month, cancer na, the next month, iba na naman. So, it depends doon sa case ng tao, but there are instances like that. And then the illness-related preoccupation is not better explained by another medical condition such as somatic symptom disorder. So, hindi pwede maging comorbid yung dalawa. Generalized anxiety disorder as well as this one, and obsessive-compulsive disorder. So, kasi nga, again, kung titingnan yung mabuti ang mga disorders na to, and if you would look at the differential diagnosis, may similar features siya, pero nga kasi again, this is solely focused on having a type of disorder and being anxious about it. As with specifiers, there are several ways we can specify the condition. Specify if it's care-seeking type, meaning to say the person always visit the hospital and always go through procedures, lab procedures and tests, or also always consulting with his doctor. And then we also have the care avoidant type wherein ito yung ayaw naman magpunta sa hospital or natatakot magpa-appointment sa doctor kasi nga ang fear naman nila, or usually they fear that the doctor will confirm that they have that illness that they are um, thinking that they have. So about 20% of patients who used to meet the diagnostic criteria for DSM-4 hypochondriasis now meet the criteria for illness anxiety disorder. So, ano ibig sabihin nun? Ibig sabihin nun, hindi lahat ng may hypochondriasis na diniagnose dati has illness anxiety disorder. Usually, it happens on the late age onset, or it happens with the latter stage of life, but that's the severe type of illness anxiety. And literature have shown that it has more of to do with the developmental stage at the time, kasi syempre pag naging na tayo 70, 60, we are more conscious of our health than we were like 40 years ago, or when we were in our 20s or in our 30s, di ba? So dahil nga matanda ka na, we know the reality that our health is not as it used to. Okay. For comorbidity, it can be comorbid with other anxiety disorders except for what was mentioned earlier, as well as mood disorder. Okay. Now we have what we call the culturally specific disorders. Now the culturally specific disorders na may kinalaman sa illness anxiety disorder are the following. So we have Koro, wherein there are some Asian cultures, they fear that the genitals will retract back or retract into their abdomen. So, but if you would notice, in the Philippines, we have that kind of parang pananakot natin sa yung mga bata, lalo na when we were trying to teach them how to pee in the proper place, particularly with boys, di ba? Sasabihin, pag hindi ka umihi dyan, mapuputol yung penis mo, or parang liliit yan, tapos babalik sa tiyan mo, yung mga ganong pananakot. So, I think it's because of course, we're Asian, so medyo siguro na-adapt din natin yan. And then we also have that, wherein the symptoms are dizziness and fatigue, which is attributed to semen loss in some Indian culture. So, ayan. I think this is also where the idea, parang kaya daw masturbation is bad, especially for men, kasi nga may mga gantong culturally specific disorders. And then we also have Kyoggyo. Okay, I'm sorry if I'm butchering the pronunciation, but this is the wind overload, which is among the Khmer people of Cambodia, wherein the fear that wind cannot circulate effectively through the body, and dizziness, weakness, fatigue, and trembling are seen as signs of this illness. We also have that kind of, or similar kind of culture-specific. I'm not sure if it's considered disorder. Wala pa naman ako nakababasang pinag-aralan na siya. Pero, di ba, with Filipinos, we have the idea of lamig. Lamig sa katawan or lamig sa likod. Di ba, pag nagpapamasahe tayo, sasabihin sa'yo, ay, ang dami mong lamig. Kaya ka ganito. Kaya ang tigas ng, yung back muscles mo. Durugin natin yung lamig na yan. So, we have that concept of lamig. Now, what are the causes of the somatic symptom disorder? This was also tackled in the video earlier. Ang sabi is that people who have or who tends to have this type of disorder have a consistent overreaction to physical signs and sensations. So, actually, which is true for some people. Uh, like for example, I have this coworker before. Um, when when we go for around the office, kasi ako medyo uh, pag close tayo, physically aggressive ako. So, I show my closeness by, ayun, nanghahampas ako, nangungurot. So, pag natuwa ako sa'yo, nanghahampas ako, tsaka nangungurot. So, siya, pag may sinabi siya nakakatawa, and, diba, and I find it funny, so I react. Tapos, yung reaction ko na yun, may kasamang hampas. So, minsan, light lang yung hampas ko, pero sa kanya, aray, yung sobrang na siya, yung parang sakit na siya. And also, this person she doesn't really like spicy things. Pag kakain kami ng maanghang, parang, uh, yung isang sili lang, anghang na kagad siya. Eh, sa akin, parang pa yon, parang weak pa siya. So, may overreaction siya sa physical signs. And this is also why she doesn't also like going to she doesn't like going to the doctor because she's afraid that the doctor might find something wrong with her body, or the doctor might find a critical illness daw pag nagpa-doctor na siya or pag nagpa-check up siya. And then whenever she has dysmenorrhea, parang ayun, namimilipit na siya sa sakit. Which is why she's surprised every time I would go to the office na I'm on my period. Sabi niya sa akin, parang bakit hindi ka uma-absent, or parang hindi kita nakikitang parang namimilipit sa sakit kahit na second day ng period mo. Kasi usually it's the second day yung medyo heavy yung flow. So therefore, masakit sa puso talaga. I tell her, carry lang naman yung sakit. So, heavy yung period, but then it was okay with me. Pero yung sa kanya pala, talagang there are instances in the office wherein namumutla na siya, as in wala nang kulay yung labi niya whenever she has a bad dysmenorrhea. So, ayan, meron siyang ganon. I think she's very sensitive to pain. So, aside from that, what they have seen is that it might be unlikely to see the cause from the biological or psychological factors itself. And it might be more on learned behavior from the family to focus on anxiety on the physical sensations, which is also, I think, very true in our case. Kasi when I remember, kasi nga nung napag-usapan namin yan, I think we also had a case like this. Kaya namin napag-usapan tong particular disorder na to. So, sabi ko sa kanya, kasi when I was little, hindi sa amin pinapaano yung pain. Kumbaga parang ang sa amin is, the pain is fleeting, so don't focus much on it, or don't be too anxious about it. Kasi kinukwento ko rin sa kanya na sa lahat ng magpipinsan, ako yung pinakasanay na injectionan or turukan. Aside from the fact na sakitin ako, I didn't really have a problem with injections or vaccinations. Ako lagi nasa unahan ng pila nun. Kasi nga, again, I was taught that the pain was fleeting, whereas on her part, she was taught that pag parang masakit, nakafocus siya doon sa sakit, not on the fact that the sensation of pain is going to be just seconds and not for a long time. It will not linger for a long time. So I think on her case, it's more of a learned behavior. So try to think about it, yung mga kasama nyo or mga kakilala nyo, or even you, in terms of reaction to pain. Okay, another cause or another thing that might contribute to the somatic symptom disorder would be the following. Of course, the stressful life events. So, the more stressed we are, the more we feel pain. So, mas makikita nyo nga yan. Like, for example, uh, stress kayo sa mga subjects nyo ngayon, di ba? So, more na mas prone kayo for physical or somatic symptoms per se, like, for example, headaches, stomach aches, those things, muscle pain or muscle tension. So those things. So these are stressful things that we usually feel when we are stressed out or in a very stressful life event. And then another might be the illness or the experience of illness in the family during childhood. So, ayan, pag may nakikita tayo noon nung bata tayo, and then nakikita natin na ayun, nasasaktan, or there are reaction to the pain in that family member might have contributed to the formation of the somatic symptom disorders later on in life. And then, of course, there are some people who see benefit in having some illness. Kasi syempre, when we are ill, ito lang naman yung time na mabait, parang mabait sa atin ng nanay natin or di tayo binubungangaan ng nanay natin. And then when we request food, di ba? Tatanungin ka ng nanay mo, anong gusto mo kainin? Para may lagnat ka. Anong gusto mo kainin? Ako na lagi sinasabi, bili niyo ako ng mommy sa sa ganito. Kasi may malapit na bilihan nun sa amin and gusto ko yung mommy nila. Or sasabihin ko, bili niyo ako ng goto sa ganito. Which is also a comfort food for me when I was sick. So, you have a lot of sympathy and you gain a lot of attention whenever you are sick. So, that's a benefit of being sick. So, sometimes, unconsciously, the people would have or would react in that manner na magkakaroon sila ng mga sakit or they would feel some sort of pain na wala naman talagang medical basis, or they would have this anxiety with sickness because of the fact that they know that they would have more sympathy and attention from others when they have it. Okay, now this is a diagram wherein, or a figure per se, wherein we can see yan, kung paano nangyayari si illness or cause ng illness. Like for example, like when the kasagsagan ng COVID, tumaas ang illness anxiety nun. Pero again, we don't say that we have disorder, illness anxiety disorder at the time because that's only a normal reaction during that particular time. Pero let's say for example, na-eradicate na si COVID. Lahat na nabakunahan. Pero, meron pa ring tao na, ngayon, nabahinan siya ng COVID positive person. So, may perceived threat na kagad siya. And then, with that perceived threat, kakaroon siya ng apprehension. Parang, nabahinan ako. COVID positive pa naman yon. So, yan, titignan niya na, ano bang napipil ko sa body ko? Do I feel parang sumiskip ang dibdib ko? Napipil ko ba na parang maglalagnatin ako? So, yung mga gano'n, nakafocus na siya sa lahat ng sensations ng katawan niya. And then, meron ring increased physiological arousal because you are really focused on what's happening to your body. And then, you're going to be doing checking behavior and reassurance seeking. So, either you're going to wash your hand frequently, tapos inom ka ng gamot, and then, or you might be contacting the doctor in order to be reassured if you have COVID or not. Ayan. And then, preoccupation with the perceived alteration, abnormality of the body sensations or state. So, let's say, for example, that time, especially for girls, they would feel this one. There are instances na mas tumataas yung temperature ng babae, especially when ovulating. So, let's say na, yun nga, na nabahinan ka ng COVID positive person, or you feel that the person might have COVID. So, at the time na eradicated na si COVID, take note of the situation. And then, at the same time, you are ovulating, so that's why you feel very hot in your body. So, yun, naka-preoccupied ka na doon na, hala, lagnat na yata to. And then, you would misinterpret, of course, the body sensation. Instead of attributing it to your ovulation, you are attributing it to the person who sneezed on you. So, kaya, ang tingin mo na, ay, COVID na to. So, perceived threat. So, yan. Paikot-ikot lang yan. So, ganyan usually ang nangyayari sa kanila. Okay, so what are the treatment for somatic symptom disorders? So, actually, ayan na naman tayo. So, limited treatment or research on the treatment. So, this is why I'm highly encouraging you to read the text, the DSM-5 TR para makita natin kung meron na bang bago. Kasi nga, this is, again, based on the DSM-5. Okay. So, mild cases of illness anxiety disorder may benefit from cognitive behavioral treatments. This is because of how it is similar with anxiety disorders like JD, OCD, diba? Detailed education and some reassurances or reassurance from medical professionals. Another would be exposure treatment. So, just like how we treat people with phobia, exposure treatment can be very effective for illness anxiety disorder. So, paano exposure? Wala, yun nga, takot siya na magkaroon ng germs, dalhin mo sa area sa hospital na maraming germs or maraming may sakit. Like, for example, yung pay ward. Doon, halo-halo sakit doon. Okay. Another antidepressant may be helpful. Again, this is because the comorbidity is high with mood disorder. Then the gatekeeper physician assigned to limit excessive use of medical services. So, for instances na, ayun nga, parang yung client ay yung sort na laging punta ng ospital at kung ano-anong lab test ang gustong gawin sa kanya, ayan. So, the physician who's always dealing with that client should limit the excessive use of medical. So, siya yung sasabi na, hindi po natin kailangan yan kasi ginawa na nga yan eh. Yung ganito, parang katulad din po yan ng nakaraang lab test. So, wala na pong need for that. Kasi nga, again, sometimes, kahit na sinabi ni doktor na wala, all clear, hindi pa rin sila naniniwala. And then, reduce supportive consequences of illness. So this is for, like, for example, family members to stop providing attention. So, kung sabi niya, samahan mo ako sa doktor kasi masakit yung ganito ko na naman. Sabi niya, kakapunta lang natin ang doktor nung nakaraan. Bahala ka dyan. Next time na. Kasi, nakailang punta na tayo sa doktor, wala namang nangyayari. So, stop giving attention. Kasi nga, lalo na kung makikita ni clinician na ginagawa niya yon to gain attention. So, yan. Kailangan itap yung support para kung yung ibang disorders kailangan ng support system, ito, kung yun yung problema, i-reduce ang support system. Okay. Now, moving on to the next one, psychological factors affecting medical condition. So, this is a particular diagnosis that is useful for clinicians actually. Kasi there are conditions na may psychological impact or psychological effect. So, like for example, patients' concentration difficulties makes it hard to take medication on time, or patients fail to comply to medical advice due to being in denial about the diagnosis. So, like for example, yung cancer, usually cancer patients ang meron dyan, kaya kasama na sa parang intervention or management plan ng mga cancer patients yung parang psychological management para ma-process yung kanilang pinagdadaanan. Kasi nga na ano sila parang nagkakaroon sila doon ng grief, or especially yung mga severe na disorders or conditions or diseases, meron silang stage na parang nagkakaroon sila ng grief or dumadaan sila sa grief stages or grieving process kasi nga they feel that they lost their health. So yun. So pinaprocess yun. And then, okay. Moving on to conversion disorder. So conversion disorder in the DSM-5 TR and in the DSM-5, ang pangalan niya talaga is this one, Functional Neurological Symptom Disorder. And it's usually called that by doctors talaga. Ito yung tawag nila. However, with psychologists, we call it conversion disorder. So the key feature here is the altered motor or sensory function that is inconsistent with the neural or medical conditions that are not better explained by another disorder. So yung kanina, meron siyang psychological effect because of a condition. Ito, wala naman talagang ganon. Pero may mga nararamdaman siya na kumbaga hindi mapaliwanag. Dapat mapapaliwanag siya kung may ganun siyang condition pero hindi siya mapaliwanag. So like for example, parang biglang nabulag. Pero pag tinignan yung mata, okay naman yung mata. Pero hindi talaga siya nakakakita. So it is often suggestive of neurological problem, but then when they do the laboratory test, no problem is detected or no such problem is detected. So this usually or this might cause significant distress or impairment. Siyempre, kumwari, biglang hindi ka nakakita, at tapos biglang nung tinignan naman ng doktor, okay naman yung mata, yung the eyes itself, and then pag chinek yung brain, okay din yung area ng brain for the vision. So bakit hindi ka makakita? So yun yung example ng conversion disorder. Okay. So it may display an indifferent attitude towards the symptoms. So for them it's not, kumbaga, it's not a big deal. And then functioning might be mostly normal, and they are not sorry for that. They are not deliberately faking symptoms for the purpose of concrete gains or malingering. So malingering, when we know that the client is faking symptom for a particular gain. Okay, like for example, parang may peperahan siyang doktor, mga ganon. Yung, kumbaga, malingering, faking symptom. Hindi talaga nila yon, or nararamdaman talaga nila yon, but hindi nila ginagawa to gain sympathy, to gain attention, whatnot, or to gain money, whatsoever. They just suddenly have that. Okay. Okay, let's have the criteria. Okay, one or more symptoms of altered motor or sensory function. So, katulad nga na example ko kanina, bigla siyang nabulag. Or, yung iba minsan yung parang bigla silang hindi nakakalakad. Pero, again, pag tinignan ng laboratory, walang problema sa legs nila or sa muscles. na maggagawa ng action ng paglalakad, and even the brain. There is an incompatibility between the symptom and medically recognized condition. So, again, yung kaninang sinasabi ko, there's nothing wrong with the physical parts of that sensory organ that is malfunctioning. However, it's not really doing its function of seeing. And this is not better explained by other condition or other diseases or general medical conditions whatsoever. And it causes significant distress, of course. Kasi, syempre, you can just imagine what will happen if suddenly you cannot see or suddenly you cannot walk. Diba? So, yeah. But then, in terms of its statistics, the condition is rare, but with a chronic intermittent course. So, matagal siya, but then, parang pasulpot-sulpot siya. And we usually have this comorbid with anxiety and mood disorders, uh, particularly seen with females, and the usual onset is on adolescents. Um, Also, ang nakikita rin nila dito based on statistics is that it's common with some cultural or religious groups. Okay. As for the causes, up until now, conversion disorder is not understood. Not in the multidimensional approach that we're using. But if we're going to isolate the Freudian view of things, uh, this might be believable. Like for example, yun nga, may past trauma ka or unconscious conflict that is converted to a more acceptable manifestation. And for this particular situation, this is the physical symptom. So like for example, may nabasa kong ganyang may ganyang case, pero that was matagal ng case yun eh. Yung teenager siya, teenager ba o parang bata pa? Parang hindi siya nakakita all of a sudden, and then it turns out na nakita niya na nakikipag-sex yung tatay niya ba o nanay niya doon sa isang kasambahay nila. So I forgot that case. It's not a story, but it's a case. I know that it's a case kasi makapal yung textbook na hawak ko nun, and then I think it's a medical textbook. So yun, parang hindi nung tinignan ng doktor, walang problema sa mata yung bata. And then it turns out that it's more, if we're going to push yung Freudian view about that case, the kid was not able to get over the shock of seeing the parent having sex with another person other than the other parent na supposedly ka-partner niya sa dapat doon. Kumbaga, seeing your parents is already shocking enough. What more yung seeing your parent having sex with another person, no? So, yun yung parang story or parang case niya. Kaya hindi siya, bigla siyang hindi nakakita. Okay? So, another is primary or secondary gains. So, with Freud, for the primary gain, ayan, Freud thought that it was an escape, or having this kind of disorder is an escape from dealing with the conflict. So, katulad nga nun sa nabasa kong case na hindi niya alam kung paano niya i-reconcile yung nakita niya doon sa fact na hindi yon yung parents niya, kapartner ng isang parent. And then, of course, secondary gain like attention, sympathy, as I mentioned earlier in the illness anxiety disorder. There, in terms of socio-cultural factors, ang nakita nila is this is much more common to people of lower education and coming from the lower socioeconomic strata. And the patients are likely to adopt symptoms in which they are already familiar with. Okay. So in terms of treatment, if the onset of the disorder is after a trauma, ang usually na ginagawa is i-process muna si trauma or treat the post-traumatic stress disorder before treating the conversion disorder itself. And then also address or remove the source of secondary gain. So if the family are the ones who is doing that, giving the person a lot of sympathy or a lot of attention, so alisin muna yon. And reduce supportive consequences of talk about physical symptoms. So ayun, kumbaga, you just treat the person normally kasi nga, the more that you elaborate on it na, bakit ka nga kaya hindi nakakita bigla? O, kawawa ka naman yung ganun. So, the more it actually encourages or reinforces for the person to continue on with this maladaptive behavior or manifestation. Okay, now we have another disorder. This is factitious disorder naman. Now, again, factitious disorder, this is different from malingering. Malingering is faking, but although factitious disorder is also faking symptoms, ayan, ang pinagkaiba nila, with malingering, there is an obvious external gain. With factitious disorder, they do it because wala lang. They're not after any gains whatsoever. Yung external gains like for example, money or being popular, like for example, yung sa YouTube, di ba? So, the person might actually induce physical symptoms or just pretend to have these physical symptoms. Aside from gaining sympathy or the benefit of the sick role, walang monetary gain per se. And to distinguish from malingering, ayan, in which physical symptoms are fake for the purpose of achieving a concrete object, like getting paid time off and avoiding military service. Sa South Korea, daming na demanda dyan at hindi na pinabalik sa South Korea kasi nga they 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 are malingering. They are found to be malingering. So they pretended to be sick. Factitious disorder, walang ganon. They are not going to get paid for it. They are not after getting time off, paid time off, or avoiding military services such as in South Korea. Okay. So, usually what happens with the factitious disorder is that there is falsification of physical or psychological signs or symptoms. So, sometimes there are patients who would, they would fake illness, and then, or they would fake, for psychological signs, they would fake being depressed. So, the individual would present themselves as ill or injured, so legit. So they go through lengths in order to para panindigan pagiging may sakit. So again, no, the deceptive behavior is evident in the absence of external reward. So take note of this. Kasi nga, ang daming nako-confuse between factitious disorder and malingering. Okay. And this is not otherwise explained. Okay. Then we also have factitious disorder imposed on another. More commonly known as Munchausen syndrome by proxy, wherein the other one, the other person is making the person is making the other person literally sick. So it's inducing symptoms in another person. So you typically it's the caregiver who induces the symptom in a dependent, like for example their child. So may nabasa akong ganyan na parang bakit daw lagi yung mga namamalimos na may dalang bata, bakit daw laging tulog yung bata, 'di ba? So, if you look at it deeper, nga no, parang when have you seen uh, these beggars carrying children na gising yung bata? So, ang isa sa mga ano nila, I think I read it on Reddit, uh, isa sa mga theory nila was that the adult is drugging the child or giving medications to the child that would induce sleepiness, like for example yung mga um, cold medicines kasi nakakaantok yun, 'di ba? So and then they do it because they would gain attention or sympathy. There's also this case I forgot the name, pero sa US siya. Tell me sa ano ha, sa synchronous class natin kung alam niyo yung pangalan. Sumikat siya sa YouTube silang mag-ina. And then, parang later on, pinatay niya yung nanay niya kasi it turns out that her mother is actually making her sick. Parang kasi ang palabas ng nanay niya was that may sakit siya. And then, parang simula pagkabata hanggang sa naging teenager siya, parang may sakit ayun nga, yung teenager. And then, parang may nakilala yung teenager sa internet na parang naging jowa niya. And they planned on killing the teenager's mother, especially after she, I forgot the name talaga. Especially after she discovered that her mom was intentionally making her sick. So that's factitious disorder imposed on another. So sinong ma-diagnose doon? Syempre yung nanay ang ma-diagnose doon. Kasi siya yung nagko-cause ng sakit doon sa anak niya. Okay, so hopefully you are all are clear sa inyo ang somatic symptom disorders. Let's move on to dissociative disorders naman. Now, for the dissociative disorders, magkatabi lang sila sa DSM-5-TR. Mauna lang si dissociative disorders kaysa kay somatic symptom disorders. Okay? But with dissociative disorders, we are talking about severe alterations or detachments from reality. Ito yung mga instances na parang you lose consciousness and suddenly you find yourself in that particular situation na parang pag binalikan mo, paano nga ba ako nakaabot dito? So, pero etong mga disorders na to, they are so severe that it affects the person's either identity, memory, or their consciousness. So, there are two key concepts that you have to understand. So, the first one is the depersonalization, wherein there is a distortion in perception of one's body or experience. Like, for example, you feel like your own body is not real, or you feel like ano ba yung sa Tagalog, parang nawawala ka na sa parang nananaginip ka. Yun, parang nananaginip ka. Whereas with derealization, we understand it as losing a sense of the external world. Like, sense of living in a dream. Sorry, magkabaligtad pala yung sinabi ko. So, ito yung parang nananaginip ka. Ito yung parang nawawala ka sa sarili. Okay? Again, in Filipino, nawawala sa sarili. Ito ay nananaginip. Parang nananaginip ka. Okay, so these are the disorders that we are going to be talking about. So, the depersonalization, derealization disorder, we have first, of course, the dissociative amnesia. After the depersonalization, derealization, and then we also have the dissociative trance disorder and the dissociative identity disorder. Okay, so what's the difference between them? So with the depersonalization, derealization disorder, this is a recurrent episode in which the person has sensations of unreality of either one's own body or the surroundings. So either yun nga, parang nawawala ka sa sarili mo or parang panaginip yung nasa paligid mo. Parang Silent Hill. Silent Hill has this environment, game environment, that it all seems like a dream, so it's more of that one. So the feelings dominate and interfere with life functioning. Yes, this is true kasi I had a client like that before. So sabi niya, the client is working as a tattoo artist. So you can just imagine, 'di ba? Parang tinatatuan ka niya, tapos bigla siyang nagkaroon ng ganitong episode. So, ang hirap. Parang ikaw din, kakabahan ka. Oh my God, ano nang ginagawa niya? Kasi nga parang sobrang wala na siya. Hindi mo na siya nararamdaman na tinatatuan ka niya. So, ang tinatanong mo, tapos hindi siya nagsasalita. So, that. And then, we also have the only diagnosis if primary problem involves depersonalization and derealization. Okay? So, kung walang ibang symptom, ito yung ibibigay mong diagnosis. Okay. Similar symptoms may occur in the context of other disorders like for panic disorders. So, this is true. There is this feeling of loss of reality or feeling of going crazy, diba, for the panic disorder. The same with PTSD, particularly the sense of derealization. Okay, next. Okay, so for the criteria, DSM-5 criteria, it's a persistent or recurrent experience of depersonalization, derealization, or both. Although reality testing is intact. So how do you test reality testing? So you can estimate the reality testing by using the mental status examination. So specifically with their orientation, the sensorium part, to see if they are still in reality. Usually they can answer that well, and in cases like that, times 3 po siya, wala siyang problema doon. Pero ang feeling, like for example, yung sinabi nga ng client ko sa akin, feeling niya nasa labas daw siya ng katawan niya. So, parang, ano ba yung tawag doon? Parang astral projection daw. Pero alam niya hindi siya astral projection because she doesn't believe in those things. And of course, the symptoms can cause significant distress. In her case, she knows that it's distressing dahil nga it's affecting her work. And it's not better explained by other conditions. Okay, so let's watch a video overview on these disorders.
Maybe you've had the experience of driving on autopilot. One minute you get in your car, and the next minute you've arrived at your destination, but you can't actually remember the details of the drive. This is an example of normal, everyday dissociation, a term that describes a mental state of disconnection from what's going on around you. Normally, this daydreamy state doesn't last very long, and most people can snap out of it if something or someone requires their attention. But for some people, dissociation is more pervasive and can't be tuned out of so easily. In fact, the feeling of disconnection may become so intense and happen so often that it stops a person from functioning in their daily life. And when this is the case, we say that the person has a dissociative disorder. Dissociative disorders are a group of disorders that can cause impaired awareness of one's own actions, thoughts, physical sensations, and even identity, which is a sense of who you are. Dissociative disorders tend to stem from trauma, usually early childhood abuse or neglect, and are thought to be a way of adapting to negative feelings and experiences. Dissociative disorders are divided into three main types: depersonalization-derealization disorder, dissociative amnesia, and dissociative identity disorder. Each of these disorders falls along a spectrum of severity, with depersonalization-derealization disorder being the least severe end of the dissociative disorders, dissociative amnesia falling somewhere in the middle, and dissociative identity disorder being the most severe. Typically, individuals with more severe dissociative disorders may have elements of less severe ones as well. With depersonalization-derealization disorder, depersonalization refers to a feeling of detachment from oneself, your own person, while derealization refers to a feeling that the world around you isn't fully real. Those with the disorder often feel as if they're watching themselves from the outside, maybe watching a movie about their life. They might feel emotionally or physically numb, or have a weak sense of self. Individuals with depersonalization-derealization disorder might speak in a deadpan manner with little emotion, and have trouble forming relationships. In severe cases, a person may have trouble recognizing familiar places, people, or objects, and this can make it hard to learn new tasks. Other symptoms include an altered sense of time, where things seem to move too fast or slow, brain fog or lightheadedness, and being prone to rumination and anxiety. Dissociative amnesia is when a person blocks out or forgets important personal information that most people would remember for a lifetime, like where they lived as a child or what their mother looked like. Dissociative amnesia can be divided into four types: localized, generalized, systematized, and continuous. Most people with dissociative amnesia have localized amnesia, meaning they have trouble recalling a traumatic event. Sometimes the memory loss is broader and includes months or years surrounding the event. Generalized amnesia is where a person can't remember any of their past, even non-traumatic parts. The onset of generalized amnesia can be sudden, stress-induced, and may be accompanied by a dissociative fugue, meaning a temporary period of disorientation and wandering or travel. In a fugue state, a person may be confused about who they are, or they may believe that they're someone else. They may also temporarily lose deeply ingrained skills. For example, a computer engineer may forget how to use a laptop. In systematized amnesia, a person only forgets a category of information which is in some way associated with a trauma, like forgetting everything about a certain person or a specific location, even if it was a significant part of their life. And finally, continuous amnesia happens when a person forgets each new event after it happens and retains nothing but the present moment, a bit like the fish Dory in the film Finding Nemo. And continuous amnesia doesn't always relate back to psychological trauma. The third type of dissociative disorder is dissociative identity disorder, which used to be called multiple personality disorder. Dissociative identity disorder can be broken down into two types: covert dissociative identity disorder and overt dissociative identity disorder. By far the most common type, Covert dissociative identity disorder occurs when a person experiences sudden and dramatic shifts in the way they perceive, think, or feel, as if they've taken on characteristics of a different person or people. Some people with covert may hear that person's voice and feel that it's speaking to them. Those with covert dissociative identity disorder are usually aware that their experience is unusual, and may feel disoriented and powerless to understand their moods and behaviour. On the other hand, those with overt dissociative identity disorder outright assume two or more distinct identities, sometimes called personalities or alters. The identities are distinct because they tend to talk and act differently than the original person. They may have opposing tastes or political views, be different ages, genders, or nationalities. These alternate identities completely take a person's body and mind, suppressing all other identities temporarily. Those with overt dissociative identity disorder aren't always aware that this is happening, and may report forgetting whole portions of their day. They may find groceries that they can't recall buying, or discover injuries to their body that they can't recall getting. And it's not unusual for some people to have a period of fugue and suddenly find themselves in a different town or city. Having overt dissociative identity disorder can potentially endanger the person, especially if one identity engages in self-mutilation or risky behaviour. The prevalence of suicide among those with the condition is very high, with almost 3/4 attempting suicide at least once in their life. Diagnosing dissociative disorders can be tricky, and some of the symptoms can be seen in substance intoxication, especially of hallucinogens like LSD, and dissociative drugs like PCP and ketamine. Other causes include seizures, brain trauma, as well as chronic conditions like dementia. Psychiatric conditions like anxiety disorder can cause an impaired sense of identity, time, and sensation, especially during a panic attack, but these symptoms usually last minutes to hours, whereas with dissociative disorders the symptoms can persist for years. Finally, bipolar disorder and schizophrenia can also cause dramatic mood swings, mimicking dissociative identity disorder. But while these depressive or euphoric moods can last for a week, the change in personality in dissociative identity disorder only lasts for minutes to hours each time. Treatment for dissociative disorders typically involves psychotherapy, so people can process the trauma safely. In the case of dissociative identity disorder, the goal of therapy is to facilitate fusion of identities, where a person's personality states are integrated and the person feels more whole. Alright, as a quick recap, dissociative disorders often develop as an attempt to adapt to severe or prolonged trauma. Falling on the least severe end of the spectrum, depersonalization derealization disorder is due to a disruption in the normal perception of events. Falling in the middle of the spectrum, dissociative amnesia is due to disruption in memory. And falling on the most severe end of the spectrum, dissociative identity disorder is due to a problem with having a single complete identity.
Hi everyone.
Alright, so that's it for the video overview um, of this particular disorder. So hopefully may tumatak sa isip nyo doon, and I'm sure there's a lot of questions waiting for me at or during the synchronous class. So please prepare those. Please write that down. Don't have an amnesia and forget na sasabihin nyo. Nakalimutan ko man po ano itatanong ko. So, wala po tayong ganito, hopefully. Okay. Anyway, continuing on with the discussion, other features of this particular disorder, the depersonalization, derealization disorder, is that we have, or they have cognitive deficits in attention, their STM, or short-term memory, and spatial reasoning. So, they tend to be also easily distractible, and they have difficulty absorbing new information. Ito yung tipong may sinasabi ka tapos biglang sabihin nila, ha? Ano nga ulit yung pinag-usapan natin? Or ano nga pala yung sinasabi mo tungkol kay ganto-ganto? Or tungkol sa ganto-ganto? And they also have reduced emotional responding. Um, from the literature of the yung mga nakita nilang brain studies, ayun, ang nakita nila meron ding anomaly with the HPA axis. So again, remember this particular HPA axis had been also implicated sa mga anxiety disorders, particularly the post-traumatic and panic disorder. Okay, so these are all the dissociative experiences scale. Um, medyo ano siya, medyo, ano ba to? Uh, Pixelated. Tingnan nyo na lang, check nyo ulit sa libro para mas makita nyo. So, ano ba yung mga dissociative experiences ng mga patients with this particular disorder? So, descending frequency ang ano niya. So, pinaka mababa ang frequency is this one. Talk out loud to oneself when alone, act differently. And then, pinakamataas ito. Surrounding seems unreal, so derealization. Looking at the world through a fog, so likely depersonalization or either. The body does not belong to one, so again, depersonalization. Okay. Did not hear the last part or part of conversation. Derealization to. And then kung makikita nyo, di ba, there are instances that we are like that. Sabi nga sa video, at times we are at autopilot when we're doing something that we usually do every day. So like for example, commute. Di ba pagdating mo sa pag nasa yuma ka na or nasa school ka na, iisip mo, paano nga ba ako nakarating dito? So, more or less, the time that you left home and the time that you commuted to the school, you were on autopilot. But does that mean that you have this disorder? No, it doesn't mean that you have this disorder. There are just instances na, yun, nag-autopilot lang tayo when we do routine things. Okay. In terms of statistics and facts, so it has high comorbidity with anxiety and mood disorder, and it affects about 1 to 3% of the population. So, I think the statistics of this one have changed because it's already 2022. So, definitely may bago na yung statistics. The onset is usually during the adolescence and usually runs a lifelong chronic course. So, it can be maintained by medications, but if you stop with the medication, it can relapse. And also having a history of trauma makes the disorder more likely to manifest. So, mas mataas ang risk factor mo if you have childhood trauma or a very neglected childhood. Treatment, research is a bit scarce actually, to because of the fact na yun nga, konti lang yung mga ganitong cases. So, more or less, it's going to be case analysis. And then, there's no systematic research on the psychological treatment. Again, because of the fact that konti lang yung meron nito sa population. And aside from that, sa 1 to 3% ng population na yon, hindi pa lahat nagpapa-diagnose or nagpapatingin sa professional. And then, they did have a trial or clinical trial for Prozac. However, it showed no effect above the placebo. So hindi pa siya ganun ka-promising in terms of the psychopharmacological treatment. Okay, next is the dissociative amnesia. So, I'm sure you have heard of this particular disorder, pero ang alam lang natin would be yung mga nakikita natin sa mga drama and movie, which are all grossly exaggerated, no? Yung parang napalo lang sa ulo, may na kagad, amnesia na. So, not taking into fact that the skull is very thick, and the main purpose of the skull is to protect the brain from serious injury. So there are several forms of dissociative amnesia, including the psychogenic memory loss. It has three types, as mentioned in the video. We have the generalized, or the one wherein we are unable to recall anything, including the identity. Localized, which is the usual thing that I see with my clients na victims ng rape or assault. They don't really have, or they don't have a complete recollection of what happened to them during that event. Or selective. So selective, ayun, uh, kumbaga, konti lang yung nare-recall niya. It can also involve dissociative fugue. Pag nagkaroon ng amnesia, there are cases like this na parang bigla siyang, ayun, hindi niya naalala kung sino siya. Tapos, mag-ano siya yung, mapupunta sa ibang lugar, and then mag-establish siya ng ibang identity. Kasi nga, di niya alam kung sino siya. Now, there are cases like that here in the Philippines, but sadly, it's not well documented, and I don't think na nado-document siya as fugue per se. Kasi may mga nababasa ko na nawala sa gantong lugar and then nakita sa gantong lugar. Iba na yung pangalan niya. And I'm not assuming that it has something to do with the syndicate or whatnot, but I'm feeling that it might be more of this condition. Because, ayan, pag tinanong mo bakit sila nandun, they are not really able to recall how they got there, or why they are in that new place. So a good movie for this particular disorder is this. This is a classic movie. Meron rin netong book, I think by Sidney Sheldon, Three Faces of Eve. So look it up. Marami akong i-drop ng mga movie title. More or less, puro classic. So, hopefully you love movies so you can understand it better. Yun lang, some of the scenes are going to be grossly exaggerated for cinematic freedom, ang sabi nga nila. Okay. Now, what's the DSM-5 criteria for dissociative amnesia? There's an inability to recall important autobiographical information, usually of a traumatic or stressful nature that is inconsistent with ordinary forgetting. So, again, hindi lang siya basta nakalimutan. So, katulad ng example nga yung pag tinanong mo anong pangalan mo, hindi niya matandaan kung anong pangalan niya. And this is not ordinary forgetting kasi our names are pretty much something that had been instilled with us as soon as we are able to talk. And even nung hindi pa tayo nakapagsalita, di ba tinatawag na tayo sa pangalan natin. So, medyo mahirap yung kalimutan. So, ayan. Pag generalized amnesia natin, siya usually nakikita wherein completely nakakalimutan na nila yung identity nila and their life history. I think a good example would be, ano ba yung movie na napanood ko kay Juwon? Yung Korean, Carter. Carter, yung ano niya, yung kanyang title, the Korean movie recently. Sa Netflix meron nun, si Juwon yung bida. And then the symptoms are cause clinically significant distress or impairment in social, occupational, or other areas of functioning. So in his case, Carter's case, it was really distressing, 'di ba? Parang pagkagising niya from may dugo sa paligid niya, he forgot what happened, and then suddenly he was surrounded by armed men. So parang may mga nakatutok na sa kanyang baril, tapos hubot-hubad pa siya. So, may mga ganong and then he doesn't know who he is or how he got in that particular place or in that hotel. So, ayun. Kumbaga, dun pa lang sa scenario na yun, sobrang distress na siya kasi nga, tinututukan siya ng baril and then, maraming dugo sa paligid niya. Tapos, so syempre, pag maraming dugo, iniisip mo may napatay ba ako or what not. Pero wala namang katawan dun sa hotel. Marami lang dugo talaga. And then he doesn't even know if he's the one who did that, yung maraming dugo na yon. Pero wala naman siyang parang injuries. Meron ba? I forgot the movie. So parang last 2 months ago ba yata yung pinanood o last month lang. Anyway, so the disturbance is not attributable to psychological effects of a substance. So katulad nga ng sinabi ko kanina or sa video, it shouldn't be because of drugs or alcohol, because there are instances na ganun din siya. Like for example, with alcohol intoxication, pag nasobrahan ka dun sa content ng alcohol na talagang nadadigest lang ng katawan, sometimes nagpa-blackout eh. So katulad nung sa ano ba yung comedy na yun? I forgot yung comedy na yan. Yung parang may ikakasal silang friend, tapos nag-bachelor's party sila. Tapos kung ano-ano na pinagagawa nila kasi uminom sila and then nag-drugs pa sila. And then the following day they forgot asan. The whole movie was revolving around hinahanap nila yung groom. Nawawala yung groom. And then when they backtrack, kasi nga nag-blackout sila with all the alcohol and the drugs that they took the night before. Hindi na nila alam kung anong pinagagawa nila. So, they backtrack. Ang nangyari pala, naiwan sa rooftop yung groom. Parang kasal na kinabukasan. So, yung mga ganun. I forgot the title of the movie. Sorry, mahina talaga ako doon. Mahina na ako sa pangalan, mahina pa ako sa title ng movie. Okay, and the disturbance is not better explained by any other dissociative identity disorder or post-traumatic stress disorder or acute stress disorder or somatic symptom or major or mild neurological disorder. So, again, it cannot be comorbid with the following disorders. Also, if there is a fugue, dissociative fugue, you have to specify that this is there. So, ito nga, again, the fugue is travel or bewildered wandering that is associated with amnesia for identity or other important autobiographical information. Okay, so the prevalence of this disorder, the dissociative amnesia and fugue, is about 2 to 7%, and this usually appears or begins in adulthood. And we don't really see this happening with children or with senior citizens. Because with senior citizens, when they forget things, it's not amnesia anymore. Likely, attribute mo na siya sa neurocognitive decline. So, it's more on Alzheimer's or dementia na. And then, it is rapid onset and dissipation. So, pag nakita mo na kagad, lalo na pag nag-fugue na siya, tapos pinaliwanag mo, usually bumabalik naman sa kanila yung mga information na dapat alam nila. So, with the causes, little is known about the causes kasi nga it's quite tricky to document them given that they have amnesia and some of them go to other places and assume other identities, diba? So, it's quite difficult to document and understand ano ba yung nagpo-cause nito. However, several literature have said that it might be due to trauma or severe stress na pwedeng mag-trigger ng amnesia nila or ng fugue. Yeah. And in terms of treatment, they have, most of them would recover or remember it without any active treatment. Like for example, yung mga psychotherapy, hindi na siya minsan kailangan. So, minsan kusa na lang siya bumabalik pag na-address na yung stress or na-address na yung trauma. Now, this one, I'm not going to discuss this anymore because it's not in the DSM-5 TR. So, maybe you can just look it up in the textbook if you are curious about it. Pero hindi na to nilagay sa DSM-5-TR because of the cultural practices. So, remember in DSM-5-TR talagang in-embrace na nila yung multiculturality. So, kaya hindi na nila inilagay to. Parang more on ano na siya. Religious cultural practice kasi siya. So, ayan. Or beliefs. Okay, now moving on. This is another curious case. Dissociative identity disorder. Again, if you have questions, please jot it down and I'll try to address them all in our synchronous classes. Kung di kayo makapag-antay, i-chat nyo sa MS Teams natin and I'll try to address them as soon as we can. Okay, so this is formerly known in other DSM editions as multiple personality disorder. However, the correct term now is the dissociative identity disorder. So, the defining feature for this one is the dissociation of the personality. So, hindi lang siya isang personality per se. So, kumare, if you believe MBTI, which is lacking in evidence, scientific evidence, hindi lang siya INTJ, ENTP pa siya, or mga ganon. So, kumbaga, marami siyang personality. So, the person who's supposed to be just one personality or one identity can adapt several new identities. As literature have said, it can be as many as 100 or just few, but the average number is around 15. And in most cases, the identities display unique behaviors, voices, and postures. So, like for example, what's the movie with yung ginawang meme si Patricia. It was not me, it was Patricia. I forgot. Ito na naman tayo with the movie names. Dati alam ko yon. But I also have a movie then, another movie aside from that na dissociative identity disorder din siya. If I remember the title correctly, it's identity ba or vacancy. Look it up, basta tingnan nyo na lang. But I do know the name of the main character. It's John Cusack. So try to look him up and try to look up the title. It's either identity or vacancy. I forgot sorry. So maganda yung plot twist nung movie na yon. Mas hindi siya glass yung bagong movie na sinasabi ko. Anyway, so siguro you can help me out by putting it in our chat box after hearing this recorded session. Okay. Next is this one. What's the DSM-5 diagnostic criteria for DID? So there is a disruption of the identity characterized by two or more distinct personality states, which may be described in some cultures as an experience of possession. So, but in this instance, this is not possession per se, because we're looking at it in a scientific perspective. So the disruption of there is a disruption of marked discontinuity in the sense of self and sense of agency, accompanied by related alterations in affect, behavior, consciousness, memory, perception, cognition, and or sensory motor functioning. These signs and symptoms may be observed by others or reported by the individual. So, but in most cases, when you read some clinical cases about this, yung mga tao sa paligid nila yung nagre-report. Kasi in most cases na documented, hindi sila aware na nagsuswitch sila with their alters. Parang later on na lang sila magiging aware na may switch na nangyayari. Most of them are become aware pag nagti-treatment na sila. And then there is a recurrent gap in the recall of everyday events, important personal information, and or traumatic events that are inconsistent with ordinary forgetting. So just like with amnesia, kaya nga 'di ba sa video, pwede rin sila magpakita ng similar symptoms with amnesia, dissociative amnesia as well. The symptoms cause clinically significant distress or impairment in social, occupational, and other important areas of functioning. The disturbance is not a part of a broadly accepted cultural or religious practice. So again, it's not, kumbaga, if the culture or if the client come from a culture na they believe in possession, pwede mo kasing sabihin na baka possession yan. Pero pag tiningnan mong mabuti, hindi naman pala possession or kasi parang may may process on how the church would say na dapat i-exercise na yan, i-exorcise, 'di ba? Pag sinabi ng mga pare na that's not for exorcism, it might be more on psychological or psychiatric case. So baka ito na nga 'yon. And for children, yes, merong mga children na may gantong cases or condition. It's not imaginary playmate or fantasy play. So they really have another person in them, which is kind of disturbing kasi they are still in the process of developing their person or developing their identity. So that symptoms are not attributable to the physiological effects of a substance. So katulad nga sinabi ko kanina for amnesia, like blackouts or chaotic behavior during alcohol intoxication or other medical condition like complex partial seizures. Okay. So, what are the unique aspects of DID? So, ito yung mga concepts that you need to know in order to understand it further. So, when we talk about alters, ito yung different identities or personality ng tao. And yung tao mismo na may alters, we call them host. So, the identity that keeps other identities together. So, siya yung nagbabahay sa mga alters na to or sa kanya na nakabahay yung mga alters na to. And when we talk about switch, we talk about the transition from one personality to another. Okay. So, this particular disorder, among other disorders, is one of the most controversial disorders. This is because yung isa sa mga widely known cases, air quotes, cases of DID was seen to be a hoax. And this is Sybil, yung libro na Sybil, if you are aware of that classic literature. It turns out that in-exaggerate nung clinician niya yung mga kinukwento niya. Wala naman talaga siyang disorder per se or DID. It's just that, ayun, parang the clinician had seen it as very parang interesting case. Kaya nung pinublish niya, parang ayun, naging may DID na siya. So, kaya very controversial tong mga to. Kaya ngayon, ang practice na nila is they really have to assess and it takes them for the practitioners who deal with this kind of cases, it takes them several assessment and evaluation so that they can be really sure that it is DID and not another condition. So what they have seen is that, ayan, some patients presenting with DID symptoms are faking or possibly subconsciously And patients are more likely to produce a fake alter when the therapist suggests this possibility. So yan, pag in an instant or instantaneous yung pag-switch niya, parang medyo nagdududa na doon yung mga therapist or yung practitioner. Kasi nga, it's more of an, parang kumbaga sa from the limited literature out there, the alters are housed between the conscious and the subconscious. No, subconscious and the unconscious. Kumbaga, pag hindi pa nangyayari yung switch, nandun, lang sila, nasa babang part ng consciousness. So, kasi nga, hindi pa sila natatawag. While some patients are not faking it, wherein there are case studies that reveal changes in physiological and brain function switching between alters. So, in this particular case, this is more believable kasi nga, ang tinitingnan nila dito, they have what we call this, scientific evidence through the brain diagram, or not brain diagram, brain imaging, brain image or brain scan that really shows that there is a big difference in the host brain scan and the alter's brain scan. So I think between the two, this is of course going to be more believable kesa dun sa kinakausap mo lang and then suddenly bigla siyang nag-switch. Kasi it's quite difficult to believe what people are saying, especially kung ganito yung case na hinahawakan mo. Okay, konti na lang, guys. Kung gusto nyo mag water break, just pause this. It's going to continue naman after you're ready to come back. Okay. Now, for the statistics, prevalence is not known. So, they have estimated it to be around 1 to 2%, and what they have seen is that it seems to be more common in female. However, this is not well established pa kasi nga, again, it's quite difficult to track then. And the onset is almost always in the childhood or in the adolescent stage, wherein dahil nga hindi pa buo yung ego or hindi pa established yung identity, ayan, nagkakaroon ng further breakdown sa identity during these stages. Kaya pagka tumanda, hindi siya nagiging molded into one persona. It has also high comorbidity rates with other psychological disorders, and it typically follows a lifelong chronic course. So, that is unless it's treated, no? So, what are the causes of the disorder? So, what they have seen so far is that people who are legitimately diagnosed with these disorders have a history with severe and chronic trauma. So often they were exposed to abuse in childhood, so different types of abuse. And what they have seen also is that the risk increases if there's no social support after the trauma. So like for example, yung American Psycho is also a good movie for this one. However, hindi alter per se yung sa kanya. Parang nung namatay yung nanay niya, parang tinake niya yung personality ng nanay niya. Tapos siya yung naging nanay niya. Parang ganon. So, ayan. Kaya ako nabanggit yun kasi nung pinag-aaralan ko to ng college, parang naalala ko yung tanong kasi nung professor ko noon, parang bakit naging ganon si Norman Bates? Kasi nga yung nanay niya very strict, very religious, and then his mother would subject him to uh, corporal punishment. So talagang pag pinalo siya, papaluin talaga siya ng matindi. To the point na it's physical abuse na talaga. And then ang sagot namin noon ng klase, it's because after he was subjected to this trauma, walang nag-check-in sa kanya na child protection services, and he does not have any other person other than his mom. Kasi wala siyang father eh. So, ayan. So, no social support after the trauma. So, as he grew older, he became more dependent on his mother, and then, nung namatay yung nanay niya, ayun din yung isa namin pinagdidebatihan. Was it identity disorder or dissociative identity disorder? Or was it delusions? Kasi he was still pretending, or he kept the bones of his mother. He didn't bury his mother after his mom died. Yung skeleton ng nanay niya nandun sa bahay. So, kaya parang iniisip namin, ano ba, may identity disorder ba to? Or meron ba siyang, is it schizophrenia, true or untrue? So, ayan. Anyway, for their mechanism or defense mechanism, ang explanation dito is that the dissociation is happening because this is a way for them to escape the impact of the trauma. Kasi nga, remember, usually people who have this disorder have been exposed to traumatic events or abuse early on in their life, and then there's no way for them to escape it. So they would dissociate, meaning to say they would look at themselves in the way na parang they wish that they are not there, or parang kumbaga fantasy na leading to dissociation, which is not a good way to cope later on. And it is also closely related to PTSD, and for others or other literature says that it might be a very extreme subtype for PTSD pag nagkaroon sila ng ganito later on, and then having PTSD as well. There is biological vulnerability, but it's not well understood pa, or di pa nila nakikita ano ba talaga yung connection. And what they see is that almost all of the risk factors are due to environmental factors. Okay. Now, in treating dissociative identity disorder, so the focus of the therapy, or the focus of the therapies should be on the integration of the identities. Kasi nga, kumbaga sa puzzle, sabog yung mga puzzle pieces. So, hindi siya nabuo. So, ang nangyari ngayon, yung identity or the puzzle itself that symbolizes the identity of the person, never siyang nabuo. Pero, alam mo na yung mga pieces na yon ay pertaining to that particular identity or that particular whole puzzle picture. Does it make sense? Hopefully, it makes sense. No? You can just clarify it during our synchronous class. And then, identify and neutralize cues or triggers that provoke memories of the trauma or dissociation. So, like for example, in the American Psycho, there was a point in the movie na nung pumunta na yung kapatid ng babaeng pinatay ni Norman Bates, parang nung nakita niya, kasi nag-imbestiga nga siya, nung nakita niya na parang yung nanay nga yung source ng trauma, pero syempre di niya alam to what point of trauma or to what extent of trauma ang meron. She tried to mimic the mother, she tried to impersonate the mother to provoke the memories of Norman Bates. And it worked with him. So, try to look at that particular movie. Dalawang version siya. Yung pinakabago, yung American Psycho, and the other one, yung Psycho, na ano lang, black and white. Yun yung original, yung Psycho na movie. So patients may have to relieve and confront the early trauma, and some of these are achieved through hypnosis. So yes, hypnosis works. However, the the efficacy of hypnosis is very limited, and it can only be used to certain types of conditions also. Okay. So in terms of false memories, so the problem is it possible to create false memories of abuse by power of suggestion? So yes. Yeah. Some patients think that they have repressed memories of abuse, which are later shown to be false, but can be very damaging to the patients and their families. So there are conditions like this wherein may false memory na ayun, parang abuse siya, tapos syempre sinabi niya din sa family niya, but it turns out na hindi naman pala yun totoo, or hindi sa nagsisinungaling siya per se, pero nasa memory niya siya. Hindi niya ginawa ng storya, pero nasa memory niya nga. I cannot explain it more elaborately because I'm not really trained in that particular types of cases, and I haven't really had that one, but I did read about them. Pero kasi more or less these cases are American cases. Wala pa masyadong nababasa na Filipino case. Okay. If those happen, the therapists, need to be well trained in memory function and be careful not to suggest an untrue story or history by mistake. So, kaya nga pag therapist ka, this is why when you become therapist, if you want to be therapist later on, you don't do the talking. You let the client do the talking. Kasi nga, in these cases, medyo mahirap magsalita. Baka may masabi kang hindi totoo, tapos i-adapt nila yun sa memory bank nila. Akala nila totoong nangyari yun. Okay. Now, let's summarize all of this. I'm sorry I went over time, but we have to finish this. So, for the somatic symptom disorders and dissociative disorders, the features of somatic symptoms, a somatic symptoms disorder are again about physical concerns, but without any clear medical cause. Whereas with the features of dissociative disorders, there are extreme distortions in perception and memory. And then for both cases of disorders, the treatment outcome or even the well-established treatments are seen to be still lacking and needs to be further studied. So that's it for today's discussion. So hopefully you have learned some, kung medyo may mga magulo pang parts, and have jotted down your questions for me so we can discuss it later on. So bye guys, I'll see you all in the next half of the term.